Welcome to UMDF's Ask the Mito Doc monthly webcast. Today we are looking forward to hearing from Dr. Russell Cisnedo with Seattle Children's Hospital about managing seizures. Our Ask the Mito Doc webcasts are made possible through the generosity of sponsors, so we ask that you join us in thanking UCB. Mark your calendars now for UMDF Mitochondrial Medicine 2026, set to take place in sunny Orlando, Florida, June 17th through the 20th. Planning is underway to bring cutting-edge information, networking opportunities, and much more to the mitochondrial medicine community. We hope you will make plans to join us. We would also like to remind everyone about our patient-populated registry. This is the ideal place to help capture the patient experience and overall journey to help us move toward cures and treatments for mitochondrial disease. Information about the biorepository can also be found at umdf.org/mitoshare-registry. Please check it out today.
Hello, everyone, and welcome to our Ask the Mito Doc for September. We've been missing seeing you for these months since June, when we all gathered for Mitochondrial Medicine 2025. And today we're excited to introduce you to Dr. Russell Cisnedo, who's going to talk to us about seizure management. Hey, Dr. Cisnedo, come on the screen so we can see you.
Okay, just 1 second. Oh,
There he is.
Sorry.
Thanks for joining us. We're really excited about this topic. I know this topic touches the lives of many of our patient families, and I think we have we'll be able to learn a lot today. I encourage those that are in the audience to place any questions you might have in the Q&A. And once Dr. Snedo has completed his talk, we'll answer your questions, as many as we can get to today. So take it away, Dr. Snedo. I'm going to go off screen, and I'll be here waiting for you.
Okay, so I'm Russ Senato, and I spent my entire career trying to understand this thing called seizures. So a little bit about my frustrations and concerns, but also subtle little victories here and there. But hopefully I can let you understand why this is such a big topic, at least in my mind. So there, just to be perfectly transparent, I've done some clinical trials in both mitochondrial disease and epilepsy, but these are my conflicts of interest, just so to be upfront, and not to belabor UCB Pharma and my I've done fenfluramine studies for them in the epilepsy arena. So what I want to do today is let's get everybody on the same page. So we'll talk a little bit about a quick overview of epilepsy, and then we'll delve into epilepsy and mitochondrial disease. And we'll try to get through these things. So hopefully I can get you to understand some of the frustrations in the field and what we're trying to do to ramify and develop more precision medicine for epilepsy. So the definition of epilepsy is 2 or more unprovoked events. So something that's provoked could be a fever, an illness, that would be a provoked seizure. But these are 2 or more unprovoked events. That's the definition of epilepsy. And what happens, we think, is that it's the abnormal synchronization of cortical neurons that result in a seizure or a rapid change in behavior, which would be a seizure. And there are 2 basic types. So I don't know if you can see my little pointer here, but so there are focal seizures here on my left, and on the right, there are generalized seizures. Focal meaning that it starts in one spot, and if you can see this little run here, that becomes rhythmic, that's a focal seizure. And generalized tends to form at both hemispheres at the same time. And over the years, we've tried to develop understanding of how this miscommunication occurs between neurons. And so our drugs are basically developed to alter different receptors within how the neuron talks one to another. So you can see this, the green thing is a neuron, and it's releasing specific neurotransmitters that signal the neuron downstream. And so there are receptors in the neuron that's communicating with the other neuron that has receptors, and they both communicate through these neurotransmitters. And so we've developed specific drugs, and you can see the names here, trying to modify the way these neurotransmitters are released. And over the years, there's been plenty of new seizure medications developed. And what we've done is we've done it by sort of like eras. So they're the first generation drugs. And any of you on the call have had seizures or probably been on one or more of the first generation drugs. And then the second generation drugs came around because we're trying to ask the question about what type, we were learning about neurotransmitters and different receptors. And these drugs were developed because of that need to address those. And the third generation is relatively recent, within 1980, 85 onward. And you can see we've got way more third generation drugs. And these drugs basically act maybe similarly or a little bit different than the other generation drugs. But we have plenty of drugs to go around. So why is this beginning to matter to all of us in the field? It's because what we found is somebody did a study in looking at the drugs up to about 1970. So first and second generation drugs. What about seizure freedom? Well, using first and second generation drugs, a large study showed that about 66% of patients become seizure free on either the first drug, which is usually about 45 to 50% seizure free, the second drug, which is about 15%. And then after you do two drugs, the third drug working is only about 3% or so. And so we get seizure freedom in about 67, 66% of the patients. So a similar study was performed later on in the mid 2015s, asking the same question. Now that we have all these new drugs, are we getting better at controlling seizures? And unfortunately, this slide is supposed to tell you no. So the same amount of seizure freedom is found with first and second generation drugs. And then when you even add on the third generation drug, it's the same percentage. Now that's very frustrating because there are particular patients that we can't control. Now, the real reason, I think, and I'll harp on this a lot, is that we're looking at the symptom of miscommunication between neurons. What do I mean by that? We're looking at whether it's focal or generalized, and we've created drugs looking at focal seizure control versus generalized seizure control. So we're trying to control the symptoms, not the etiology. Precision medicine is trying to move us to the point where we're trying to correct the etiology of why somebody has epilepsy. And part of the precision medicine movement has been really shuttled into the forefront by genetic testing. And in a recent genome-wide association study, somebody did a really nice study and predicted over 900 different genes responsible for epilepsy. Unfortunately, we don't know all the 900. We know, and we have validated approximately 140, 150 of these genes. And they're all listed here on a timeline similar to the timeline of the drugs. It's very similar, very interesting, but happenstance. So we're finding that many of our patients are now genetically determined to have an increased chance of having seizures. Interesting, huh? So, but we're still stuck because all of our trials have been trying to counteract symptoms and not the etiology. We haven't started until recently looking at these genes as a possible etiology for seizures. And if we correct the expression of these genes, can we stop seizures? So let's summarize quickly. So epilepsy is defined as 2 or more unprovoked seizures. Seizures start either as focal or more generalized. So we have 2 different types of seizures. Since the introduction of many new medications in 1990, the rate of medically intractable seizures hasn't changed. Approximately 30% of the epilepsy population remains intractable to our medications. Now, the responder rate hasn't changed between all the new developments of seizure medications. There's part of my frustration. So 67% before 1990, and afterwards, recent study, 69%. That's hardly any difference. So it's probably our medications aren't working because it's not related to the population change. It's more related to we're treating focal versus generalized. And since all our medications are based on trying to do both of those, or one of those, it stands to reason that treating the symptoms can only get you so far. Now, let's shift over. So there's a lot of continuity between mitochondrial disease and what we're learning over time and the epilepsy world. Now, just like epilepsy, so intractable epilepsy or epilepsy occurs in about 5% of the population, which is huge. Mitochondrial disease, less so. So we know it's about 1 in 4,000, and most of you on the call already know this stuff. But what's interesting is several studies, including our site that we published, about 20 to 45% of all the infants that we see have a primary mitochondrial disease, which is quite high. Now, the interesting fact is that 80 to 90% remain intractable to the seizure medications that have been developed. That's really poor. And in our series, 70% of this 20 to 45% were under the age of 3. Now, you want to ask yourself the question, well, if there's so many patients who have mitochondrial disease, who have epilepsy, why doesn't everybody with mitochondrial disease have epilepsy or seizures? Something we really don't understand yet. But to tell you how distinct it is, there are only 2 types of mitochondrial diseases that have names that the criteria is to have seizures. So we're saying that there's a large proportion of mitochondrial patients who have seizures, but there are only 2 types of syndromes or types of mitochondrial disease that actually you have to have seizures to have the diagnosis. One is in pol gamma 1 disorder and Alpert-Honeylocker syndrome. So that's a nuclear mutation. And then there's one mitochondrial DNA mutation called MERF, which is a mutation in the tRNA for lysine. That part of the definition is you have to have seizures. Well, geez, if it's just mitochondrial dysfunction, then every patient with mitochondrial disease should have seizures. But that obviously isn't true. So if there's a similar mechanism to what's causing seizures in mitochondrial disease as causing seizures in the random epilepsy population, we should be able to control 60% of their seizures because we do it in epilepsy, just based on the symptom. But I'm sitting here telling you that isn't true. There are probably, like I said, 70% who have intractable epilepsy. So there's something different about mitochondrial disease that we haven't really addressed yet for seizure control. So in the epilepsy world, if we treat a genetic reason for that epilepsy, can't we control seizures? And we're beginning to get some answers with this. And so there's a gene called SLC6A1 that gives you a disease called Deuce syndrome. And it can be treated with a ketogenic diet someone. But if you don't respond to the ketogenic diet, you develop a terrible epilepsy called Lennox-Gastaut. And what some people have found is that you can repurpose a drug that acts on a specific receptor in the neuron called GAT1. And GAT1 is responsible to reuptake too much GABA, which is a neurotransmitter, an inhibitory neurotransmitter. And it leaves it in the space and you get overactivity of inhibition. And so you change the balance of control and you get seizures. But phenylbutyrate, which is interesting because it's a urea cycle drug, has been found to allow the GAT1 receptor to stay open longer, which means that it takes up this excess GABA inhibitory neurotransmitter and levels the field and puts things back in equilibrium. And the interesting thing is not only does it really reduce seizure activity, but it dramatically improves cognition. And so here's precision medicine at its best, we think. One gene, one out of the 190 so validated genes in epilepsy, and we've picked one now, and that one seems to have an answer, precision therapy. Now, in mitochondrial disease, there are 450 genes that we know are associated with mitochondrial disease. Through the work of Anthony Mutha and the group at Mass General with the mitochondria, and recently another study has shown that there's probably around 480 genes associated with mitochondrial disease, but I'm saying 450 over right now that we're pretty sure that cause mitochondrial disease. And of these 450 genes, minimally, 75 of these genes have been associated with frequent seizures. So now we're starting to talk about mechanisms, etiology of why epilepsy may be happening or seizures may be happening in the mitochondrial disease population. But here's the catch. These 75 genes are associated across mechanisms of how mitochondrial disease can be altered. OXPHOS subunits, membrane function, cofactor biosynthesis. The list is long, and I just listed the easy ones to kind of comprehend here. And so if we want to treat etiology, our drugs aren't based on these things here. They're based on whether it's focal or generalized. Now, another problematic, this is one of my patients, and this little girl has both generalized tonic seizure and she has focal seizures. So if you're developing drugs to treat just focal seizures, you're missing the generalized seizures and vice versa. So that's one complication. Our drugs in epilepsy are made for focal versus generalized as a rule, but there's a lot of cross coverage. So what don't we have? But what do we have? So the glass is half full in some respects, so that we know that there are treatable types of mitochondrial disease. Now, these are very, very rare, but they're treatable. For instance, biotinidase deficiency, which is on most newborn screens, beside having baldness. If you have this, you just add biotin and you correct the problem, and the patient becomes completely normal, really. Thymine for transporter defect, and thymidine pyrophosphokinases 1 deficiency. Adding thymine can correct these, stop seizures, enhance development. We just learned on a NAMDAC talk that for coenzyme Q10 biosynthesis, if you take a part of the CoQ10 molecule, this may correct the disorder of CoQ10 biosynthesis abnormality. So that's something to keep track of. The ketogenic diet for pyruvate dehydrogenase deficiency is very helpful, but it doesn't produce really 100% in the patient's seizure freedom, but it's helpful. And there are other rare vitamin and cofactor deficiencies. So what we need to do in the community is to figure out what's treatable. And usually what's treatable is through genetic testing. But once you have a treatable, then you just add the cofactor and you're pretty well treating the problem. But there are also toxins, and we know this from mistakes that, not only I've made, but many others. And the use of valproic acid for whole gamma-induced disease. Valproic acid becomes a toxin to the liver, and you get liver failure, and you don't do well. The use of vigabatrin for GABA transaminase deficiency. So genetically, if you find this, you stay away from vigabatrin. So, it's like having a bad costume on Halloween. You want to stay away from the really bad costumes because you won't get any candy. Now, interestingly, the group in Europe decided, well, they would have a working group and talk about seizure control in primary mitochondrial diseases. So what they came up with was a list of focal seizure drugs, where Keppra and lamotrigine were first line. And in generalized seizures, lamotrigine, levetiracetam, which is Keppra, and valproic acid, when it's not whole gamma, are really good drugs. But what we've shown also is mitochondrial disease, you can have both, focal and generalized. And when you look at this, the consensus for the mitochondrial working group is really no different than the consensus that we in the epilepsy world have been using for the last 10 years. And are we controlling seizures? Not really. Takeaway message, my view of the consensus statement, we're still asking the question about treating the symptom and not the etiology. So we really need to look at what are the etiologies of the 450 or more mitochondrial diseases that have epilepsy, and we need to figure out how to treat those better. Precision medicine in mitochondrial disease, yeah, it's coming. So the NDUFS4 mouse, which is a Leigh syndrome one, this is really interesting. One in the generation minds, Vamsi Mutha at Mass General has found that there's a novel small peptide that he can use that decreases oxygen binding to the hemoglobin. And if we give this small molecule to this mouse that will develop Leigh syndrome and die early, the mouse has no symptoms. Not only is the mouse seizure free, but the mouse is Leigh syndrome free, which is pretty phenomenal. So he is starting to do a clinical trial looking at Friedreich's ataxia because he needs numbers in a clinical trial. But most of us are really anxiously awaiting the results of this, because this may be the magic bullet for many mitochondrial diseases to treat not only the symptom of epilepsy, but to treat the disease as a whole. Now, I don't want to give you the idea that treating the etiology is always going to treat epilepsy. So here's a recent case study that was published. And this little 3-month-old, he developed symptoms of muscle disease. They got gene testing, and at 3 months, he was found to have 2 pathological variants in TK2 gene. And as we know in our field and with UMDF, there's a treatment. You give the nucleotide treatment, pyrimidines, and it corrects the disease. And yes, in 9 months, it took him up to 9 months to enter a compassionate use protocol. And he got the substrate enhancement therapies, and he had better head control. His heart got better and his enlarged liver got better. But what they failed to realize is that the pyrimidines don't get into the brain very well. And so what happened is he started having seizures and nobody was really paying attention. And unfortunately, he died in status epilepticus at 18 months of age. So we can't relax. Just because you think you can treat the etiology doesn't mean that the treatment actually gets to the brain where epilepsy starts. So this is just a checkpoint for all of us to not get too relaxed in what we do. We still have to be vigilant. So how do we start to find precision in treatments? So my favorite disease is Alpers-Honeylocker. So the group in England and in Norway did a pathological study looking at patients who had died from Alpers-Honeylocker disease. And what they found is, if you look at this panel here, see these dark little structures? Those are interneurons, which house inhibitory neurons. This is a normal control that happened to die from another reason. And out of the same area in an Alpers-Honeylocker patient, you can see that the little dark interneurons are missing. Well, if it's missing, is this the etiology of terrible seizures in Alpers-Honeylocker? It may be. And why we think so is because the interneurons, it's inhibitory. This little cartoon on the right side. And then counterbalancing it is excitatory glutamate neurotransmitter. And what you want is right here. You want an even balance between inhibitory and excitatory. And when you have the loss of inhibitory neurons, you get an imbalance. And so the bully in the room now is the excitatory neuron, and it takes over, and you have terrible seizures. So how can we interact and change that? Well, we can use GABA-enhancing seizure medications. In this case, it's clobazam, lamotrigine, and cenobamate. Or we can add drugs that target enhancement of the interneuron, which is Epidiolex and fenfluramine. We know that from our studies in Dravet syndrome, which the interneuron is lost as well. Or since there's too much excitatory amino acids, we can try to inhibit those with particular drugs. And there's really a novel glutamate drug coming out that we're beginning clinical trials, and we're anxiously awaiting the results from that. But early phase 2 studies are really exciting. So we may be able to target precision medicine in Alpers-Honeylocker by using GABA enhancers and then glutamate inhibitors. So let's summarize. Problem with epilepsy is we've been treating the symptom and not the etiology. As we learn more about the genetics of epilepsy and seizures, we can start treating the etiology, the gene problem, more effectively. So that's precision medicine. In mitochondrial disease, we need to treat what we can treat the cofactor deficiencies that we know are. And then we need to learn more about the etiology of how the different genes that are causing epilepsy in mitochondrial patients, what's driving them, like we're finding for Alpers-Honeylocker. And we need to correct the etiology. That's the main focus of controlling epilepsy, is treating the etiology. So now that I've confused everybody, I think it's time for questions and stuff. So I guess I can stop sharing, right?
It sure is. Oh, it sure is. I'm coming back on camera, Dr. Snato.
Okay. So
And we'll be going through some of the Q&A that has been submitted.
All right.
For those of you that have submitted questions, please know that While I'm addressing your questions, I may paraphrase them a little bit so that they serve a broader audience. So the one I want to get started with, Dr. Sinedo, just because I hear this so very often, let's talk a little bit about the ketogenic diet, the keto diet. What should parents be thinking about, parents or adults? What considerations should be made, and how do you go about considering that for one of your patients?
Uh, well, one, whether you're G2 fed or an oral eater will dictate the different types of high fat diets that you may be able to tolerate. A 4-to-1 diet, which is classic ketogenic diet, if you just go in your cupboard and pull out one Triscuit, that one Triscuit has all the carbohydrates you're allowed per day. Everything else has to be fat. So you can tell that that's going to be hard to do, but you can do that through G2 very easily. Now, whether you tolerate it or not, that's a different story. For oral eaters, we often do the modified Atkins diet, which allows you 20 to 30 grams of carbohydrate per day, and then you can mix your meals, and it's a per day thing. And most of our patients, if seizures are reduced, buy into the modified Atkins diet and do pretty well. We use it for PDH deficiency right away when we know that. Now that DCA didn't get FDA approval, we're kind of bemoaning the fact that ketogenic diet's been around in that syndrome for a long time. But we're finding that some of the mtRNA synthetase things, drugs or genetic defects, can be helped by the ketogenic diet. We just published a paper looking at FARS2, and at least in tissue culture, if you limit the valine, the tissue culture cells do much, much better. So we're starting to see more precision medicine there. Alpers honey locker is still a work in progress. We're trying to manipulate different inhibitors and enhancers of glutamate versus GABA. And since we are doing that, that's more precision medicine. What we also know is that the ketogenic diet has a mTOR enhancement part of it. Really, it's not an enhancement, it's a inhibitory part of it. But it can also enhance mTOR in a certain population. And so in the Lee syndrome mouse model, if you give mTOR stimulators, you can alter the disease course and you can help seizures. And so oftentimes in Lee syndrome, we think about the ketogenic diet. Now, vatiquinone didn't get FDA approved either, but that's a really good medication that we found for seizure control, but the FDA didn't like that either. So hopefully we'll figure out, another drug like vatiquinone. So the ketogenic diet can be helpful.
I have another question that's within this question in the Q&A. What about the side effects of seizure meds? My thought is there anything that a patient family could do to kind of limit the side effects or make them less?
Well, one is to use less of them.
Mm-hmm.
And so we try to use no more than 2 to 3 seizure medications at one time. Seizure medications, because they were invented to treat focal versus generalized, they are shotguns. They're heavy hitters. They really do their job well. But because they do their job well, the normal activity of neurons talking to other neurons is also altered. So for instance, when you're learning, let's say you're learning to write CAT, you're stimulating certain neurons in your hippocampus, and you're stimulating them over and over again. And when you stimulate them over and over again, you're increasing their activity until it becomes so entrained that you think of cat, and in your mind you see a cat and you can write it. And that's what we call making synaptic connections. When you have seizures, what happens is those synaptic connections are frayed and you lose them. So you lose that memory. Well, our drugs are developed for epilepsy to inhibit the synchronization of networks. stimulating of particular networks that induce synaptic connections to allow you to have more seizures. That's called Kimball. So learning and reducing seizures are part of the same process to different degrees. So our epilepsy drugs can be very cognitive challenging to a patient because we're inhibiting the learning process of stimulating particular networks of neurons to learn a new task. And so you don't want to use too many because you're causing the diminishing of those networks to be stimulated. And so the benefit of the third generation drugs is that it minimizes side effects. So if possible, you want to use the third generation medications more than the second generation.
Well, that makes a lot of sense. The next question I have for you is that they have learned through surveying, I'm guessing, that there's a large number of LHON patients that report seizure activity. Is there anything specific that a patient with LHON could do to control their seizures or to prevent them?
You know, that's an interesting question. You know, there's never been a study for, the 11778 mutation that's the most common that causes Leber hereditary optic neuropathy. But, I would say, just in my own mind, it'll be interesting to see what gene transfer does once it becomes clinically available, because that is a genetic that's been tested through a phase 3 trial, and hopefully that'll be accepted, and hopefully using that will help seizures, but certainly we don't know. And certainly, like any symptom, seizures, you would go through your rubric and try to use the least offensive drug to control that seizure. And so, I would use one of the third generation medications to start.
There's quite a few questions that have popped up about stroke-like episodes. Can you give us as simple as possible how a stroke-like episode and a seizure are the same and how they're different?
Well, usually in my mind, when you have a stroke-like episode, downstream brain is demanding more energy, and that extra demand is causing more blood flow to try to go to that area. But the mitochondrial is dysfunctional within the capillary beds of the arteries that take the blood to that portion of the brain. And that part of the brain that's not getting enough oxygen now, and glucose is starting to die off. And so the manifestation of the stroke is actually where the stroke happens, and if it's in delicate neurons in a particular region that can produce seizures, that's where you get seizures. Now, there's something that I've wanted to try, and I'm starting to try in my knee loss patients, is that there's a genetic type of vasculopathy, which is what we would call MELAS. And we're seeing benefits using Epidiolex. And Epidiolex works really well in the Sturge-Weber group. And it's the same problem with imbalance between how the brain is demanding energy and this loss of vasculature around that brain area. So Epidiolex may be a good medication for MELAS once you start to have seizures. We don't know yet, but etiology-wise, it's starting to make more sense to try Epidiolex as first line. Now, the problem is Epidiolex is only FDA approved for Dravet and Lennox-Gastaut and tuberous sclerosis complex. So you have to fight your insurance companies. But it's a pretty easy sell, really, if you just give your insurance company the data suggesting that it could be helpful for vasculopathies, and since MELAS is a vasculopathy, to give it a go. And Epidiolex doesn't have very many side effects, so it's a good.
Well, one of the questions was about oxidative stress, as measured by glutathione, as this description, and ketone test. Is that something that could trigger or be a mechanism for seizures?
The short answer to that is yes. The long answer to that is it's likely due to a process called ferroptosis, and it's GPX4 driven. And so we need better drugs to treat GPX4 and enhance its activity. And that would reduce the glutathione loss that is eaten up by oxidative stress in the lipids. Now, we're getting there. We're starting to get drugs that are somewhat beneficial for GPX4, one of which was vantiquinone, which didn't get FDA approved. But researchers like Stockwell at Columbia University are really into this and looking at small molecules. And in one patient who had a primary GPX defect, we assayed 10,000 different compounds, and he actually found one that worked. So it's just a matter of effort right now. But we're learning more about it, is what I'm trying to get at. And we'll find better medications for GPX4 enhancement. And I think down the road, that's going to be helpful for a lot of different syndromes that we're dealing with that can cause seizures.
A question about medications for seizures. Do they differ in children and adults? Or are they pretty much the same?
Only an amount.
Okay.
So we dose children by their weight. In adults, we figured they're all fat, and so we just give them a dose that's been shown in a normal weight adult to be effective. And we start there, and then you add or subtract depending upon side effects.
Are there any like health habits that people could institute into their daily life through diet or whatever that could help prevent seizure onset if they don't already
Just
have
like
them?
any disease process, a good diet. And I think that the folks at CHOP has shown that mitochondrial disease patients have poor diets. Two is good sleep. And mitochondrial disease patients, if you do a sleep study, most of them have fragmented sleep. So we need to figure out how to get people better sleep. And I think that's an area, hopefully, that over time we'll learn more about, especially in mitochondrial disease. Not much is known about sleep other than it's fragmented. Nutrition, good sleep, and healthy habits. So you shouldn't go out and my Kara often goes out drinking and gambling and staying up late at night and raising all sorts of heck around the world. You can't do that with mitochondria. So it's just have to live a good balanced life.
What about neurosurgery as an option for seizure control? Can you talk a little bit about what's out there and what
I
you
think
see?
what we're learning is, and we're starting to do some of it here at Seattle Children's, is for intractable epilepsy and not being treated by different drugs. We're starting to think about the use of deep brain stimulation on children who are older. And that's where you stick electrodes into the thalamus and you overstimulate the thalamus to downregulate abnormal signals that are coming into the thalamus producing seizures. And we're starting to think about using deep brain stimulation for terrible dystonia that can happen in mitochondrial disease. And hopefully those modalities will start to be more teased out. But there is some literature on deep brain stimulation for not only mostly in abnormal movements in mitochondrial disease, but dystonia. And one of the big problems with dystonia is sometimes it's hard to tease out what's seizure and what's dystonia. And so that's a process that we're learning about too. So there's not one thing that fits everybody, but as you tease out etiologies, hopefully we'll figure out what's better for what sort of movement disorder or seizures that a patient's having.
I have another LHON question. Is it possible that valproic acid taken over time could trigger an LH1 from kind of revealing itself? And again, is there any specific medicine? You did talk about some when we talked about LHN earlier, but is it possible that something like that could be the trigger?
Well, anything's possible, but we don't know why there's such a penetrance difference between patients who have like the 11.11.778 mutation. And why is it mostly guys that get it and not women? Estrogen protective, it's testosterone causative. We do know that smoking is a trigger for many patients. Why? We really don't know. And Mark Tonoplowski thinks that sunlight can be a trigger in some patients. So he recommends sunglasses sometimes, depending upon where you live. So, that's a work in progress, and we need to learn more about what is actually the triggers. Now, you're not going to be on valproic acid unless you have seizures. And so, I don't know the data on seizures and then propagating typical retinal and optic nerve findings as levers. So it's possible, but that I have no data on.
What is the effect of the progression with a stroke-like episode, and what does it do to the blood vessels? We had a question about that. That's not one I've ever heard before. Was wondering if you have any insight.
Well, I guess since the capillary beds are where the mitochondrial are dysfunctional, and little arterioles, that probably is necrosed and dies. So downstream, you're losing all the brain matter because those don't exist anymore. And so you're losing the mechanism to get blood to that area. In other words, nutrients to that area to function. So theoretically, like in Moya Moya, you might be able to bypass some of that by producing more blood vessels around the stroke-like area.
I have a question here that I don't know that I understand it. I'm going to say it, and if it's something that doesn't have anything to do with the topic, let me know. Is capital PENS more likely to be diagnosed for mitochondrial disease? I don't know what that means, PENS.
Oh, okay. So that's when you have what looks like a seizure but isn't driven by cortical activity.
Okay.
And no, but there are a lot of movement disorders in mitochondrial disease that look like seizures, but they aren't. And so a parent looking at their child would go, that looks like epilepsy to me. And they would bring the child in, we would get an EEG, we would capture the movement, and no, it's just myoclonus. So it's not driven by the cortex. So theoretically, it's not a seizure, but it looks just like a seizure. Well, you do that enough to a particular provider, and the provider is going to look at the parent and go, oh, Billy's here again. It's not going to be a seizure. So he's going to call it a functional neurological condition, which is a non-epileptic event. And so, the family's going to get labeled as little Billy has these. Sorry to use Billy as little Sally as a patient, But little Sally's having real events, but they aren't seizures. But it's the provider that needs to show the parent that it's not driven by the cortical activity. It's driven by something deeper in a brain or a spinal cord. And it's just sort of an activation, self-activation to do a quick jerk. Essentially, we all have those. It's called sleep myoclonus, and we all jerk as we go to sleep. I swear my wife kicks me a lot. She goes to sleep and she says, "No, it's just my sleep myoclonus." I think it's volitional. She kicks me, but all of us have a little bit of that anyway. So those aren't seizures; those are driven by just abnormal stimulation of dorsal root ganglion cells. You just kind of jerk a little bit. The same thing can happen when you're concentrating, giving a talk, and somebody comes at the door and says, "Hey, Russ," and you do that. Startle reflex. But some startles can actually be reflective epilepsy. So we have, so for instance, when I was a resident, we had a priest that had these abnormal movements every time he smelled a cheeseburger. And we thought he was just faking it. So we brought him into the EMU and we brought him a cheeseburger, not from the Cleveland Clinic, but we went out and got a good cheeseburger and gave it to him. And he smelled it, and sure enough, he was firing. And we said, these are real, and it's in an area of your brain that we could resect it. And he goes, I sort of like the smell of cheeseburgers. Don't take it out. I can live with this. I just go blank for a couple seconds, and I don't drive anymore. So he was fine with it. But so there are things that look like epilepsy that aren't, that you can get called PNAS, but they're just, sometimes it's part of your disease. Sometimes it's part of something else. So that's why we bring you into the EMU, hook you up, and try to reproduce one of your symptoms, because then we could tell, well, it's not functional. It's just something else. It's a startle, or it's benign sleep myoclonus, or something like that.
Here's a question sort of related to something you said. I feel like I'm about to black out from time to time, but I snap out of it after a quarter of a second or so. Is that seizure activity or potentially seizure activity? Is that something they should get checked out?
Likely not. We all have those moments when we're sort of foggish, going into a brain fog, and then you kind of snap out of it. Sometimes it's related to lack of sleep. Sometimes it's related to just being super tired, big day, and you're kind of decompressing. Other times it's, we say this to parents, little Sally's really bright and her teacher's really boring. And she's just checking out because, you know what? Teacher's boring. She's not learning anything. And the bird on the tree outside her window is much more interesting than her teacher. Now, the teacher would say, I give such good lectures. All my kids love me and they always pay attention. Sally is having a seizure. We get that a lot. So there are a lot of other circumstances that are just normal little glitches that we all go through that aren't seizures, but sometimes can concern you.
It's an interesting question, and I don't know if it has a short or long answer, but what causes the lesions in metabolic strokes, and is there a document describing this phenomenon?
Essentially, yes. You can tell that you get tissue death by the MRI findings, and there's a mixed phasogenic signal that we see in MELAS and stroke-like episodes. It's the lack of oxygen to that area that's causing breakdown in cell swelling. So we sort of know what's causing them. They're just not getting enough energy. They're not getting enough fuel. And so the cells die. And by MRI scans, you can see sort of the aftermath of cells dying. So like in a real stroke, same thing. You don't get enough oxygen. You don't get enough nutrients into that area because you've got a thrombus in this case. and not the capillaries that are little arterioles that are dying. And so in that area, so that area dies. And on MRI scan, you can see it. And it's diffusion weighted. And so you get a mixed vasogenic and uh, diffusion weighted abnormality in the area of the stroke-like episode. And so you sort of know what happens. Same thing would happen in a regular stroke. So one's due to a thrombus of some sort, and the other one is due to this mismatch of oxygen need and nutriment need, and not enough blood vessel to get it there. The end product is pretty similar, and that's why they call it stroke-like.
Mhm. This is the last of these questions that I'm going to ask. This one's kind of long, but I think it brings up a topic we haven't discussed yet today. I'm going to read the whole thing because I feel like there's a lot in here. In mitochondrial disease, we see interneuron deficits and excitatory, inhibitory imbalance driving seizures, but also depression, anxiety, and cognitive symptoms. In LHN, for example, mental health challenges are common even without seizures. How might precision interventions being developed for seizure control also inform strategies to address these psychiatric and cognitive outcomes? And what would it take to design implementation approaches that integrate both? That's a lot. But basically, do you think that if they did find very specific interventions for some of those things, that some of the mental health pieces would improve?
It's a difficult question to answer because a lot of the behavioral problems, we don't really understand the etiology. We don't understand in totality why mitochondrial patients are more likely to have certain types of neuropsychological problems, like depression, chronic depression, like bipolar disease, like schizophrenia-like symptoms. It depends probably, well, it actually does depend on what neurons, what brain area, and the population of neurons within that brain area, and what's living and what's being pruned away. And that's something we don't know. And if you don't understand how a process occurs, treating it is, you're sticking your thumb in the hole in the dike and hoping that it's
Right. You don't know whether that's what's really
and so
impacting
you're
it or
just
not.
throwing things at them. And we learn some things like in depression, chronic depression uh, is likely a serotonin depletion problem. And you give SSRIs, which are serotonin reuptake inhibitors, you increase the serotonin and depression gets better.
Right.
And we know that constant stress from having a chronic disease depletes your serotonin. So patients need more serotonin. And then they don't sleep well because melatonin is made from serotonin, and melatonin gets you to sleep. But if you don't have enough serotonin because you're stressed out, you don't sleep well, which stresses you more, which depletes your melatonin more. And so it's a cycle.
The cycle.
And so you need to start treating some of that. But the etiology point, nobody really understands.
All right, our very last question for the day is sort of in honor of Mitochondrial Disease Awareness Week. Our theme this year is hope, and I wanted to get your take on the idea of hope within reach. So give us your spiel.
I think that mitochondrial transfer for all mitochondrial related diseases that are due to mitochondrial DNA are treatable with mitochondrial transfer. So that is my simple answer to a complex question.
Well, thank you so much for joining us, Dr. Sinedo. And for everyone that's on the line, I just want to remind you that we have two upcoming Ask the Mito Doc webcasts that are scheduled. One is on October 29th. This is an interesting one. Fact versus Fiction, Sorting Science from Speculation in Mito Treatment. We're really excited about that one, dispelling some myths. And then on Thursday, November 13th, we have our Ask the Mito Doc on genetic testing in mitochondrial disease, what patients and families need to know. And this will be a team of genetic counselors working with us. All of our past Ask the Mito Doc webcasts and other helpful videos can be found on our YouTube channel. Here's a helpful tip so that you don't have to remember the link, but if you just go to umdf.org and find the YouTube symbol, it'll take you right to everything. So again, thank everyone for joining us, and especially giant thank you to Dr. Sinedo for this very, very informative hour, and we'll see you all next month. Thank you.
Thank you, everybody. I appreciate your time.